and every member who is viewing this. She's a professor of ophthalmology at All India Institute of Dr. Rajendra Prasad Center for Ophthalmic Sciences, All India Institute of Medical Sciences. Her field of interest is cornea, cataract, and refractive surgery. She did fellowship in this field from Moorfields Eye Hospital in London. As we all know, she is one of the most energetic and enthusiastic secretary AIOS has ever had in its history. A lot of initiatives have been taken and implemented, especially during this COVID period, in the interest of the members of AIOS. She's never stops learning nor teaching, and her organization skills are par excellence. It's a continuous process for her, like breathing, eating, and sleeping is for us. So her life is nothing but ophthalmology. And the most wonderful thing is that she tries to impart some passion to people around her. I am being one of the fortunate for that. So she seems to believe that perfection is like chasing the horizon. So keep moving, madam. I present you to our society for a nice talk. We expect a nice talk from you.
Thank you so much for that kind introduction, and perhaps the words which have been said even I didn't know, but they seem to be true. And thank you. It's always a pleasure to be speaking at this forum, and especially with your own people and students. Welcome, Dr. Mesqua. I remember still fond memories of the stay that I had in Baskin Palmer with you all, 1 week stay. So, and thank you for inviting me, Anita and Anil Radhakrishnan and Sujit. I would be talking to you about pterygium and pseudopterygium, and we all know what pterygium is: fibrovascular degeneration of the conjunctiva, generally located in the interpalpable region and more often nasal than temporal. And there are various factors which have been implicated, like increased UV light. That's why it tends to occur more in our country, more in the age group which is older and more with males. And although patients, if they have a pterygium which is not that large, may complain of redness, irritation, dryness, tearing, but they can have decreased vision when it involves the visual axis or there's induced astigmatism or tear film disruption. So if the pterygium is small, then only conservative measures can be given, like lubricants and sunglasses, and patient may not be worried about cosmesis part. But sometimes you do have to do surgery, especially which would depend on the extension of pterygium, patient discomfort, and cosmetic appearance. And it is important that you document the growth towards the visual axis, and there may be induction of with the rule astigmatism, there may be inflammation and discomfort, recurrent episodes of Delin, and sometimes patients just want it for cosmetic indications. And long-standing cases may also have white cholesterol staining of the cornea, which may occur. And there are various surgical techniques which have been described, such as primary closure of the conjunctiva with the bare sclera technique, conjunctival autografts, limbal conjunctival autografts, conjunctival rotational grafts, flaps, and amniotic membrane grafts. And simple excision with the bare sclera tend to have a high recurrence rate to the tune of 38 to 88%. The gold standard, of course, is the conjunctival autograft, where the recurrence rate is lower. And in a meta-analysis, it was clearly shown that it was found to have lower recurrence rate to the tune of 0 to 17%. And amniotic membrane grafts do have a role to play, especially in cases where glaucoma surgeries may be required later on, because for large pterygia or double-headed pterygia, they do play an important role.
Yeah.
So the recurrence factors for the pterygium risk factors are young age, fleshy pterygium, non-translucent, high-grade pterygia, increased inflammation. And when you have a corneal recurrence, then basically it will appear as a fibrovascular growth. And when you have conjunctival appearance, it will show bunching. And there are various adjuvant therapies in pterygium surgery, which includes beta radiation, thiotepa, mitomycin C, 5-fluorouracil, and antivascular endothelial growth factors. But I think mitomycin C has stood the test of the time. Beta radiation was tried earlier, but there were a lot of complications like scleromalacia, necrosis, perforation, endophthalmitis, and sudden onset of mature cataract, so it was given away. And mitomycin C is the one which is most currently being used, and it has been shown that when you use it in the concentration of 0.02 or 0.04% for 5 minutes, the recurrence rate is 8.3 to 8.6%. But when you decrease the time to 3 minutes, the recurrence rate goes higher. So we have to balance the complications due to mitomycin C vis-a-vis the eradication of the pterygium. And again, a 10-year study demonstrated 25.5% recurrence in mitomycin C group, which compared with 6.9% where limbal conjunctival autograft was used. But the mitomycin C is useful in cases of recurrent or in cases of high-grade pterygia, and this is just to show how one would do pterygium excision. It is important to mark the area of the pterygium which is done with the gentian violet, and then the head of the pterygium can be it can be removed. And generally, when an instrument like crescent blade or a lamellar dissector is injected underneath it, you can actually behead the pterygium, and this is being done with the crescent blade here. And after this, the entire fibrotic tissue has to be removed. And subsequently, from the bulbar conjunctiva, one can mark the area from where the graft has to be taken, which can be ballooned with the help of a subconjunctival injection, which consists of xylocaine and adrenaline. And the conjunctiva can then be separated from the underneath tenons, and thin layer of conjunctiva is then placed in the area of the bare sclera. And then subsequently, one can apply fibrin glue, followed by the conjunctival graft which had been harvested. An advantage of these intra-OCT microscope is perhaps in case of recurrent pterygia, when it becomes very difficult to see what the underneath fibrovascular tissue is and what is the thickness of the cornea underneath. Then this is followed by a bandage contact lens application. Now, sometimes you do have recurrent pterygia such as this, and then in these cases, you do need to actually behead the pterygia and then also use mitomycin C. And we also like to use diamond burr to smoothen the surface. And after using the mitomycin C, 0.02% for 5 minutes, one can again harvest the conjunctival graft and can then place it on the surface, on the bed. And then this trick of crimping the edges of the conjunctival graft with the adjacent conjunctiva also does well, because it helps to completely attach the graft to the underlying sclera as well as to the adjacent conjunctiva. Now, this is a case of pterygium excision where conjunctival autograft has been done in the same case at post-op day 8, which clears up well. And this is another case at post-op day 12, which clears up well. Now, sometimes you can have pseudopterygia such as this, and here again the fibrovascular tissue would be there underneath, and it will be difficult to insert your instrument underneath, so it has to be dissected. This is a case of chemical injury, in fact, where pseudopterygia has formed, and the fibrovascular tissue has to be actually pulled out from the fornices and then excised, so that this fibrotic tissue doesn't come again to cause recurrence of the pterygium. And this is then subsequently followed by the glue which is placed on it. And again, this is a large pseudopterygia, so amniotic membrane is being used here with the help of the fibrin glue. And this is then placed so that to cause the apposition of the area which has been dissected to the, not only to the almost half of the cornea, but also to the conjunctival surface. And then this is followed by the application of a bandage contact lens. So this is yet another case. We now have an intraoppository microscope, and we tend to do all our cases. In fact, it's a great tool for corneal as well as ocular surface procedures. This is again a case of pseudopterygium from which the dissection of the fibrotic tissue is being done so as to reach the underlying cornea, and IOCT helps you to know the clear distinction between the cornea as well as the fibrotic tissue which is present overlying it. And this is all the fibrotic tissue which is being dissected, and like I said, pull it towards you and then dissect it so that it doesn't come back again, because you don't want that thing coming again. The bleeders are then cauterized, and then of course one can always put mitomycin C there. The graft is being fashioned from the bulbar conjunctiva, and just like I showed you, it can be then adhered with the help of the fibrin glue. And this is followed by amniotic membrane here, because there was some foreshortening of the fornices in the medial side, and you want full movement there. and this is followed by a bandage contact lens application. Now, there can be complications of pterygia surgery, which could be intraoperative or post-operative. Intraoperative could be deep dissection, excessive cautery, damage to the muscle, perforation can occur, bleeding can occur, canalicular damage could be there, or could be reversal of the graft. And there can be post-operative complications, one of which we've already shared, recurrence and graft-related complications. Donor site complications have also been described, and generalized complications, which can be vision threatening or could be non-vision threatening. This article has beautifully summarized all of the and there can be sclerothenic, delayed conjunctival epithelialization, iritis, and similifron. Scleral thinning has been reported after the use of mitomycin C in cases as high as 2 to 19%. And one has to be, that is why, careful in using mitomycin C. Again, delayed conjunctival epithelialization also has been incremented to the use of mitomycin C, the incidence of which is 4 to 5%. And similifron can occur in 2 to 10% cases, which occurs more if you use bare sclera rather than a conjunctival graft or amniotic membrane transplantation. Then there can also be corneal Dellin, which can again occur with all kinds of surgeries and adjuvants. But Dellin has never been reported after amniotic membrane transplantation, which is very much, understandable because of the epithelialization of the surface. Then you can have complications such as astigmatism with a bare sclera in 6% cases. Then you can have pyogenic granuloma if too much of conjunctiva has been handled. And then you can have graft-related complications like inflammation, contraction of the graft. There can be hemorrhage underneath the graft, but that doesn't matter because that will take care of itself. There can be an inverse graft and graft necrosis, and that is something that needs to be tackled with. You may have to put an amniotic membrane there or may have to do a repeat graft surgery. Then edematous graft is also known. Then there can be pyogenic granuloma when too much of handling is done. And when you have a granuloma like this, topical steroids have to be given first, and of course it doesn't respond, then you may even have to excise it and maybe apply amniotic membrane over it. Now, some of the complications that I would be showing you with surgical videos is this. This is a case of recurrent pterygia with the corneal haze, and in this case again the fibrotic part has to be excised. You may have to do even some amount of keratectomy here. And then depending upon the depth at which the keratectomy has been done, after placing the conjunctival autograft, one can place an amniotic membrane or can place a bandage contact lens over it. Then there's an entity known as double pterygia, where you have temporal and nasal pterygia both, such as this. And this is a rare phenomenon, but it can occur in a country like ours, where sunlight is in abundance. And it may involve the pupillary axis or it may spare the pupillary axis, and generally it tends to be more extensive, more symptomatic, and these are again difficult surgeries, and you can't do LCAT in these cases or can't use limbal stem cells because they themselves are associated with focal limbal stem cell deficiency. And then there's this technique which has been described by Dr. Hurst, perfect technique. Of course, I do not have any experience in this, but it is extensive removal of the tenons as well as the conjunctiva, and this is too drastic a technique, and I don't know if any of the other panelists do have experience with this. Now, sometimes you can have a double pterygia such as like this, and we thought that we would do a lamellar keratoplasty, but we realized that there were perforations which are present underneath this, and so it was not possible to do a lamellar keratoplasty, and iris was actually adhering. So double pterygia can be very tricky, especially if the patient says that they have undergone surgeries elsewhere, and you may have to resort to a full thickness penetrating keratoplasty in some of these cases. Now, again, to show you video of the multiple pterygium surgeries with corneal thinning and perforation, for which lamellar graft was done because there was a desmetocele there. So in this case, lamellar graft is being fashioned, and it is being sutured with 10-0 monofilament nylon sutures because of the presence of the desmetocele perforation, and the synetia then being relieved at the end of the surgery. And this is the post-op picture. Then you can have scleral melts such as this, and here we describe the technique of sutureless tuck-in scleroplasty. So basically, what is being done here is that a tunnel is being made here with the help of the crescent blade, 360 degrees all around, and this is a bit of scleral tissue which is being taken, which is placed into this area, and this is tucked in just like what we would tuck in a lamellar graft with the help of the fibrin glue, which is causing edge-to-edge apposition as well as surface-to-surface apposition, followed by again putting a conjunctiva with the fibrin glue. So this is sutureless tuck-in scleroplasty for cases of melts, and we've done now 5 such cases with very good results, and this is the post-op picture of the same. And this is follow-up at 3 months, and you can hardly make out that there was ever a scleral melt there. And then sometimes you can have surgically induced necrotizing scleritis or SINS, which has to be managed as one would with immunosuppressives and resection of the necrotic tissue with amniotic membrane transplantation or corneoscleral patch graft. So to conclude, the current gold standard for clinically significant pterygium is excision with conjunctival autograft because this has low recurrence rate. And there are numerous other techniques which can decrease the recurrence rate also with the application of the mitomycin C, but that has multiple adverse effects, and so one has to weigh the complications thereof vis-a-vis the surgical technique that you're using. And for primary pterygia, perhaps mitomycin C can be avoided, but for recurrent pterygia, one has to resort to the use of mitomycin C. So thank you very much for your kind attention.
Thank you so much, Dr. Sharma, for an exhaustive, and I think you have covered everything about pterygia. I think this was one of the best pterygium talk I have heard so far.
I think
really great.
It was more about complications than about pterygia, because that is what we encounter often.
And that is what everybody should know, because pterygia otherwise it looks like there's a very innocuous surgery, but we have seen that so many things can happen. Do you want to comment anything on stem cell transplant in such cases, maybe mini slat or those kind of things?
I think
Guillermo is also here. Yeah, please.
Mini slat has been done, and I think Guillermo will have more experience on mini slat. I've not done too many, just done a couple of them, and it is believed that stem cell pterygia is a focal stem cell deficiency, and so a mini slat would also help in those cases. But I personally, I feel that limbal transplants are very precious tissues, and I wouldn't like to use them for pterygia. But of course, I'm sure the other panelists would like to also give their comments on it.
Guillermo, you want to comment on it for recurrent pterygia at least?
Yeah, I was 2 years ago. I was asked by the Academy of Ophthalmology to do a intense review of the science of the evidence for pterygium, and I think the most important thing is to have a thin conjunctival autograft and remove as much stimulus as possible. Maybe not 180 degrees like Dr. Hurst, but the more the better. And about the use of limbal explants, I think those work well on pseudopterygiums for partial areas of limbal stem cell deficiency. There is evidence that show that taking a graft with the limbal support does help in recurrent pterygium. So that's what I can share.
Great. So,
what about
Anil? Yes, please go ahead.
No, it's okay.
Ma'am, please go ahead.
No, I just wanted to know, because you have some experience with mini slat.
Yeah, so I had done recently one. So this was, but basically a recurrent twice or thrice it had already recurred, and really bad. It was covering almost whole of the cornea. So in the area where there was stem cell was deficient, at that area I just placed 3-4 transplants. But I do agree with you that for a routine primary pterygia, I don't think that I would like to remove my limbal tissue at all.
I agree with that.
Anita or Anil, Sujit, do you have any comment on this? And then we'll move on to the next talk by Dr. Namrata Sharma.
I think we can move on, because